I often say healthcare is not expensive. What's expensive is administrative bloat, profiteering, price gouging, fraud.
Welcome to the Business of Healthcare podcast from the Center for Healthcare Leadership and Management. The center is based at the Naveen Jindal School of Management at the University of Texas at Dallas. The show, like the center, brings together business leaders and other forward thinkers to discuss how best to meet the challenges of a rapidly changing, increasingly complex healthcare industry. I'm your host, Dr. Bob Kaiser, Director of the Master's Program in Healthcare Leadership and Management for Professionals. The last time I looked, we were publishing the 71st edition of the Business of Healthcare podcast. One of my favorite interviews was episode 31, Massively Replicating Fixes in Healthcare with Dave Chase, creator and co-founder of Health Rosetta. That was in February of 2019. It's long overdue for a catch-up with Dave. Welcome back to the Business of Healthcare podcast, Dave.
Thanks, Bob. Loved the last conversation, and as mentioned off air, I am a regular listener, so I'm honored to be back.
Well, thank you. I mentioned the previous podcast because I actually want our audience to go back and listen to it again, for it laid out a pretty good baseline what you're doing with Health Rosetta at that time. Let's see if we can accomplish the following today. I think it's a big order, but we'll try this. I would like for you to refresh our audience with Rosetta Health Blueprint. And then you've got a new program I'd like for you to discuss. We'll ask some questions about it. The Health Rosetta Employer Program. It's just recently introduced. And then you've got a new book out. This is your third book, Relocalizing Healthcare. The future is local, open, and independent. And that sounds like a powerful title. So that's a lot to cover. So let's start, if you don't mind, with the Rosetta Health Plan Blueprint and how it got started.
Yeah, I mean, it got started, out of some negative situation of, some personal tragedy of seeing, a complete system failure that had really ruined a friend's life, and just asking why a lot and saying, we're a country of problem solvers. Like, how can this be? And sure enough, I went on this scavenger hunt in some sense 10 years ago and really cranked it up over the last several years to say, who solved this? We make both a true and aspirational statement on our website. We say healthcare's fixed. Join us to replicate the fixes. And the point is, all the solutions to fix healthcare from a structural standpoint have already been invented. They've been proven, and they've been modestly replicated. They're not the mainstream, of course. We've got a long ways to go. But the real puzzle is, how do you replicate that in the face of a lot of obstacles? And so that's why I created this organization. And so when I found these solutions, we laid out this blueprint. And in a sense, what I am is just Johnny Appleseed, right? These solutions are out there. I'm spreading these seeds around. And whether it's, the underpinnings of a health plan that are kind of boring stuff, but really important, or the actual care delivery and payment side, there are employers in every corner of the country, rural, urban, public, private, large, small, that are literally spending 20, 40, even 55% less per capita with superior benefits. And so that's exciting, and it's fun to share the story, and I'm sure we're going to talk a little bit more about that.
Well, I've heard of this blueprint referred to in somewhat of a comparative fashion. When you're building new buildings today, there's a lot of concern about the energy and environmental design. And if you have a LEED, L-E-E-D, LEED certified building, that's an organization that really took to heart those conditions, those situations for the environment and the design. And it was a leadership play. I mean, they said, we're going to lead the way. We're going to find the way to do that. I kind of get the impression that's what you're doing here with Rosetta Health Blueprint. You're trying to lead the way and show people that there are significant things that they can do that you don't really have to reinvent, but you have to get educated on it and figure out how to do it. And that's the hardest thing, I think, is this thing called the status quo. I mean, we've got, 50 years? I heard someone refer to our healthcare system as a history of mistakes over the last 50 years. And it's really difficult to change that. So what are some of these Health Rosetta principles that you have within your framework?
Yeah, I mean, LEED is a great analogy, because the built environment's kind of like healthcare. It's very entrenched, very local. And essentially, just like a building can be leaky, it can be polluting, so can health plans. I often say healthcare is not expensive. What's expensive is administrative bloat, profiteering, price gouging, fraud. And so what's in the blueprint is how do you get the right foundation built, just like in a building. And in some sense, I'd describe it the way, somebody describes great food these days: local, organic, and sustainable. It's local. Healthcare is local, right? What's more local than interaction between a doctor and a patient? This movement is organic. It's kind of from the ground up. It's not from some legislation. It's just what's working. And it is sustainable. People have been saying for the longest time, this isn't sustainable with healthcare. Well, this actually is. You have employers like Rosen, where they've been doing it over 20 years cumulatively. As they grew from 500 employees to 5,000 plus, they saved $400 million. So what's in the blueprint? A good example is proper primary care. There's no country in the world that has a well-functioning healthcare system not built on proper primary care. Unfortunately, we've done our best to destroy primary care in this country, but it's getting rebuilt brick by brick. Actually, not terribly far from you. Tyler, Texas. We have a somewhat similar thing, not as far along in Denver and Seattle. You can get great independent primary care, owned locally, controlled locally, unconflicted in a place like Tyler, Texas. Actually, Dallas is getting pretty good. There's an organization called the Catalyst Health Network that's a group of independent primary care. So that's a very foundational part of the blueprint. And then from there, of course, you need things like drug coverage. You need things like hospital coverage. And those are two areas where, if you think about it, a leaky building, these are really leaky. Drugs actually don't have to be that expensive. There's a lot of shenanigans going on in the drug supply chain that are very addressable if you pay attention. In fact, Caterpillar, the tractor company, really the only thing that they've done at real significance as an employer is their drug supply chain. They really have gotten after it. They haven't seen overall healthcare costs go up just because of what they've done in the drug supply chain. And then in the hospital coverage, your listeners probably have heard of something called PPOs, Preferred Provider Organizations. These are networks of who you can go to on your health plan. That probably made sense at one time. Unfortunately, PPO networks don't deliver value anymore. You generally, rent that network, if you will, for the privilege of wildly overpaying on care. The National Academy of State Health Policy just released a healthcare cost tool. And RAND just came out with a study recently as well that shows we're often paying 2.5 times Medicare rates, which do cover cost despite what hospitals say. And oftentimes in a place like Dallas, it's very common for hospitals to be charging 5 and 10 times Medicare rates, which is pretty abusive on the working middle class.
Yeah, on that topic, I understand that come January that transparency is going to be invoked. And why would you go to a hospital locally here that has 5 times and you can go to one that has 1.5 times? Boy, you'd like to think, why is there a differentiation there? And what does one offer that the other doesn't offer? So I think that's going to be quite revealing in terms of transparency awareness. I know that it's interesting. I've interviewed a few other authors here on the Business of Healthcare podcast. And Dr. Marty McCary, he references you in his book, The Price We Pay.
Yep.
And Dr. Vivian Lee, she had a book out recently, a new book called The Long Fix. The long fix kind of fits in line with your strategy of it's going to take a while to invoke these new ideas. Then recently, Dr. Brad Spellberg, The Broken, Bankrupt, and Dying book. And every single one of these books, they uncover and show how bad, awful our healthcare system is. And as like we suffer from wage stagnation because of these things. I mean, it's like every element that you can think of, we can go back to the healthcare system and say, public spending is just outrageous. All these different things that are part of healthcare. But I hear you say, Dave, that things are working. They're just not distributed outward. Yep. Is that the case?
That is the case. And, we can certainly be critical of things. And, I don't pull any punches. In my previous book, I had, we've gone to war for less than what healthcare has done to America. But you know what? Like, going back to that food analogy, the food movement that's been going around the country, it really got traction when they started talking about the positive attributes of local high quality food. It takes care of the farmers and the workers, and it's just better, tastes better for you. Same thing here. We're investing more than enough money to not only fund a world-class healthcare system, but to fund the other things that drive 80% of health outcomes. And so a lot of what we're doing is just resetting expectations. I mean, in fact, we're only a 7-person organization in terms of our core team. And most of what we talk about tends to be for employers, maybe 50 or more. But even so, I will say I have better benefits today with this kind of bootstrap, self-funded, nonprofit, public benefit corp organization than when I was at Microsoft in their heyday and you didn't pay a dime. It was all you can eat. Well, how can that be? Well, because I have much better access to great primary care. And I've had back problems like a lot of people have had back problems. And guess what? It's the number one driver of the opioid crisis, back problems, the number one driver of disability and opioid prescriptions. So our status quo system can put you in harm's way when we have incredible talent, incredible resources. We've been paying Cadillac prices, been producing Pinto Health outcomes like, let's get a great car. We're paying for it. And it is actually out there. And it's really inspiring when you talk to these organizations. And, we could do a whole series on just case studies of these organizations. What does that mean for the cashier at a convenience store in Wisconsin, or the forklift driver in Montana, or the maid in Florida? I mean, I've got great stories in all of those and many more. So let's have high expectations. It's there. It's working. You just got to adopt it.
Well, I like the concept here. As you mentioned, you are a small nonprofit business, but you are leveraging more and more people to get on board with the concept and philosophy. Now, these benefit advisors, tell us a little bit about that. I recall from our previous podcast that you were recruiting benefit advisors to take a pledge. What was behind that, and how did that outcome fulfill its expectations?
Yeah, I mean, as I dug into this area, because I didn't know about health benefits really, other than signing off checks and being a recipient. And I just started asking why a lot, like why do we have all these different dysfunctions in healthcare? And it always came back to the way we purchase healthcare. I'm like, okay, who facilitates that purchase? Well, for half of Americans, actually more, there's brokers for Medicare plans as well. It's these people called benefits brokers, sometimes benefits consultants, benefits advisors, and the best of them. And that's really what we've modeled our program on, just as lead accredited architects, the, quote unquote, architects of health plans are these benefits consultants. The best ones are amazing. They're worth weight in gold. Unfortunately, the way the industry was set up, they're out there positioning themselves, representing the interests of the buyer, but they're paid by the seller. That's a guarantee of conflicts of interest and lack of disclosure. So the pledge you mentioned, we have for the employers, the purchasers, in the lingo of the industry, plan sponsors. There's a plan sponsor bill of rights for the employer. And then for the advisor, there's this code of conduct. And then the adjunct to that is a disclosure, compensation disclosure form. We found up to 17 undisclosed revenue streams that the employer had no idea about. If you're new to this segment, these seem like motherhood and apple pie statements, but unfortunately, they're the polar opposite of what's the norm. And so, 1,500 brokers have started the process. 214 have made it through so far. We're not trying to maximize the number. We're trying to get the right people and then have an equilibrium between the demand side and the supply side.
So that's really a grassroots initiative, and it impacts the local environment when people hear about that. And It's just like being at the soccer field, watching your kids play, and the moms and dads are sitting in the bleachers talking about things.
Yeah.
That word's going to spread. Tell me about your benefits. Tell me about how things work. Because I know it's on everybody's mind, especially now. This cost has just gone outrageous.
Yeah.
And, we are all frustrated with getting bills that we don't understand and all those mistakes that we hear and we read about. And I think one of the concepts that is starting to become a little bit more apparent is that it is a long fix. I know when I talked to Dr. Brad Spellberg, he said it's like New Year's resolutions. Every year we start the year again and say, well, it's time to look at healthcare, and we don't do anything about it.
This episode is brought to you by the Center for Healthcare Leadership and Management, the definitive resource for healthcare management education in North Texas. The center is based in the Naveen Jindal School of Management at the University of Texas at Dallas. It plays a unique role in training the next generation of healthcare leaders to meet local, regional, and national demands. The Jindal School uses its strengths in accounting, administration, finance, marketing, and information systems to educate highly qualified personnel for healthcare administration and executive leadership positions. The center is home to 7 healthcare leadership and management programs, including undergraduate and graduate programs, as well as executive programs for physicians and working professionals. For more information, visit us online at jindal.utdallas.edu/healthcare.
You talk about when people adopt the Health Rosetta process, you've got this constant improvement cycle, and it's got a feedback loop on it. Kind of share with our audience, how do you go about getting people to look longer term and really adopt the Health Rosetta process?
Yeah, number one, it's just the mindset shift. One, that it's a solvable problem. Two, that you need to think, like if you're a purchaser, you need to think in the way a corporate IT security manager thinks, where they know what kept their network secure a year ago doesn't keep it secure today. What's keeping it secure today won't keep it secure a year from now. You have to, and unfortunately in this analogy, the healthcare industry, there's people waking up every day betting, which has been a good bet for a long time, that employers will stay asleep at the wheel. And so you have to have countermeasures for that. And so that's the key thing is those countermeasures are available. And you see, yes, it does take a while. LEAD is a great example where it was probably 20 years to fully mainstream that, even though there was a lot going on 10, 20 years ago. And to go back to the Tyler example, here's one of the things that's really interesting in terms of the dynamics. If you try to solve everything top down, one mega thing, it's just a lobbying war, and the status quo is going to win. However, we see this kind of rule of threes dynamic, where in a given locale, and we look at, there's 775 cities with over 50,000 people. There's 226,000 companies from 50 to 5,000 employees. You break that down and you say about 10% will tip a market. So that's about 30 companies or so. We see this kind of interesting rule of threes where in a given locale, like a Tyler, Texas, 3 employers do this. Nobody notices, but you're building muscle, you're building knowledge in that market. And then you get to 9. Then some people are starting to notice some of the providers have different contracting and they are familiar with these cards. And then when it gets to 27 and beyond, like what you see in Tyler, CEOs can't keep their mouth shut. When they're spending 40% less with superior benefits, they can't keep their mouth shut. So everybody wants it.
They got bragging rights, right?
Yeah. And the advisor there, Rachel Means, a year ago, she had to turn off new client spigot. She had so much demand. She's caught up and she can handle it. She's reminded me. But she had so much demand for her services. And in both cases, this case, you got the employers, you've got the advisor, and you've got primary care and the provider organization. So primary care has really been rebuilt there, which is great. That's how you actually start to chip away at this. And typically, again, 10%, some people even say less, will tip a market. And like LEAD, it wasn't even. It was places like Austin and Boulder and Denver and Seattle and Portland that were early adopters of that, proved out the ROI, and then it massively replicated.
Well, that mindset change, shifting mindset is not easy to do. You need to be incentivized to do things like that. You had mentioned that one of the big problems we have right now in the U.S. healthcare system is the primary care. It's been strongly diminished. And you make reference to properly incentivized primary care. What do you mean by that?
Well, we have this fee-for-service system that's pervasive in healthcare.
Right.
Through a variety of factors, there's been a strong incentive for health systems to acquire primary care practices because they can drive typically $5 to $10 million of referral value. There's actually a little battle going on in North Carolina with a physician group, and they're saying it's $14 million. The hospital is saying these docs leaving and violating their agreement from the hospital's perspective is $14 million. So the primary care has become milk in the back of the store to basically, if you only have 7 minutes on average in order to make a good living to hit your so-called, in air quotes, productivity targets, what can you do in 7 minutes? I don't blame primary care for the opioid crisis, but it's part of the perfect brew that happened where when you have undermined primary care, and the second most common reason people go to the doctor is for lower back pain, and you need to get people in and out, what can you do in 7 minutes to cover everything, right? One of the ways you get out the door is you order a test, you prescribe, you admit a hospital, you do some referral, and they were given bad information. So they were just, and then there was other things. I mean, I had 12 major drivers of the opioid crisis, and one of the other drivers was patient satisfaction being a driver, which sounds good, but bad if you have drug seekers. That really created this toxic brew. And even to this day, after all the awareness around the opioid crisis, we still prescribe at 5 times the rate of most countries, which is really unfortunate. And when you have proper primary care, guess what? A Rosen Hotels, their prescriptions are at 1/6 of the level, not because they had some anti-opioid program 20 years ago when they started. They just do it right. They've got behavioral health. They've got physical therapy. They don't have to rush people in and out. So these are the types of things that you just got to get right. It's not rocket science, but you just got to get it together.
Okay. Well, let's shift gears here to the new Health Rosetta Employer Program. My first impression is if I wanted to buy a franchise, I'd like to feel like there are some resources that are all lined up for me and some type of templates and tools and, different things to make me successful. So is that what you've done here with the new Health Rosetta Employer Program?
Yeah. I mean, you buy a franchise, you get the operations manual. That is one of the core deliverables, for a franchise. And it's exactly that. We did that for advisors as our starting point. And we found employers want that same thing as they have had that mindset shift. Like, okay, I need to get the playing field leveled. How do I have the right tools and education, as you mentioned? And that's what it's about. It's about education tools. It's also community, right? They have common set of challenges, and knowing somebody else who's been through the change. Healthcare is a fraught topic. You have to be thoughtful about how you do it. Change management's a big part of it. And so being able to have that community, and one of the things I'm most gratified about what we've created culturally in our movement is, we sometimes shorten it as give 1, get 10. It's this whole open source thing. If you give your idea, rather than holding your idea like Gollum, in Lord of the Rings, but you actually give it, you get 10. Because everybody is contributing, mixed metaphors, rising tide lift all boats. And
right.
Same thing in the employer areas. Some are ready to pull the trigger. You bet. We got resources. We can help them do that. We do things like plan opportunity summaries where it's sort of like a second opinion on your health plan. Mm-hmm. But for people who just want to start that education process, it's just a monthly membership. If they want to stay on 3 months, they get all they need, they can dump. There's no long-term commitment. It's just, let's give them the information. Let's make them informed buyers. And once you're aware of the stuff, you can't unsee it, then good things happen.
Where's the sweet spot for that? Is it a certain size employer? I'm trying to think of a large company or a large healthcare, like here at the University of Texas, Dallas, we have, all the people that work in Texas get the same program. Yeah. Would someone at a high level, as you ask us to go influence people, would someone at a high level actually look into this curated content and prescriptive guidance that you can provide?
Yeah, I mean, it is going to kind of vary based on the size, right? It might be a VP level person at a very large organization, could be a CFO or even CEO in a smaller organization. It's basically somebody who's got essentially decision-making authority over the health benefits process. The sweet spot, I would say, is 50 to 5,000 employees. I mean, you can, learn from it. If you're under that, certainly the large organizations can get benefit, but the mid-market's kind of the sweet spot. They're big enough and meaningful enough to move things. Often there's still lots of family-owned businesses, and they have a real sense of duty and commitment to their employees that sometimes larger employers don't have. And frankly, there's just more complexity at jumbo employers. I think that's one of the big fallacies in healthcare, is that if you want to impact healthcare through the employer channel, you go to the jumbo employers, and it's great. They want to do something like Walmart's done some great stuff, and Lowe's and PepsiCo and Caterpillar with like centers of excellence. Great. I'm all for that.
Right.
There's some low-hanging fruit with pharmacy spending, but the reality is those are enormous aircraft carriers. And normally, and I've been involved in introducing new software and new categories in the space. It's really a step stair your way up, right? Larger the organization, the more they want reference accounts. And if you're a 10,000 person company, you don't want a reference from a 50 person company. Maybe a 7,500 person company is okay. And for a 7,500 person company, a 5,000 may be okay, and on down the line. And so we're like, just step stair your way up. If somebody's ready to go and they got great leadership at the top, great. Yeah, state of New Jersey, 800,000 people on their plan. In 3 years, they saved $1.6 billion just on their pharmacy spend. So you can do it. It's more fraught.
Is there a networking capacity within this new program? I know you're a Microsoft guy from way back, and I'm an Apple guy from way back. We're both technology guys, but the Mac user groups, that's what we used to go after the status quo at the time was IBM and others.
Yeah.
And those Mac user groups, they all networked and shared best practices. I kind of see that's what you're doing with this new program.
Yeah, and that was one of the things, just on a self-reflection basis, I realized was actually a unique skill that I had built out Microsoft's health partner ecosystem. I didn't do all this, but today it's 28,000 partners just in healthcare for Microsoft. It's almost a $3 billion a year business. And so that dynamic, Lead's done it in the building space, but the tech partner ecosystems is very much like that. So if you look at our ecosystem, we have, kind of concentric circles. We've got our own team. We've got these advisors. There's 214 of them. And then as you span out, it's now tens of thousands of people that have downloaded the book, joined our community and all that. Some, pretty light touch, others very involved. And going back to an earlier topic, one of the things that's really interesting, and I think COVID is sort of an accelerant on this, is the other thing you see is career switchers. We do one cohort a year. In this last cohort, we have a former hospital CEO, a CEO of 21 different hospitals. We've got three clinicians, I think 2 PTs and a physician, and a former recent senior White House policy advisor who they actually see, wow, this is a lever that I didn't know about. And even if I can only impact 50,000 people, that's a difference maker for 50,000 people, because that might be, how many people they have in the health plans that they're responsible for stewarding.
There's something good about feeling like you can make a difference, that we're not helpless, that we're not stranded out here without any resources at all. So all of that is good. So let's wrap up this podcast. I want to hear about your new book, Relocalizing Health. The future is local, open, and independent. And before you tell me about it, this is your third book, and you approach this book writing process just a little bit different. So people can go get your book for free. They can download that PDF And I've done it, and I started reading your new book just recently. It just came out. And I want to buy it also, so I'll go on Amazon and pick it up and get it on my bookshelf so I can walk around and show it to people and say, hey, check out this new book from Dave Chase. Pretty good. So tell me about your new book and why'd you write it?
Yeah, it's really one where it became very clear that people needed the next level of guidance. I mentioned change management earlier, and then with COVID, I really believe, we already had this generational shift that we're on the cusp of. Already millennials are the biggest generation in history, biggest chunk of the workforce today. Expected to be millennials, post-millennials, 75% of the workforce in the next 5 years. So you already had that. But then now we've got this COVIDian sword slicing through the Gordian knot of our status quo healthcare system. That's really an accelerant. And things change. I do believe, and I'm not the only one to say this, that COVID is like a World War II-like event. If you look at major changes in national approaches to healthcare, in the U.S. with the employer system, the U.K. with their national system, something else is going to emerge out of this in the coming years. And we've had both parties in full control. We're fiercely nonpartisan in what we're doing. And fortunately, I've become friends with a guy that's a real transformative thinker, the most transformative thinker I've met of people I've worked with, including Bill Gates. I mean, he's that kind of level person. And the future of healthcare as local, open, and independent is directly pulled from his system change model that lifted tens of millions of people out of poverty in India and is remaking a key part of the food system in the States. It's about 25% of our food inputs. It's a very different approach. The essence of it is you find microcosms of success. You apply a little business know-how, a little technology, sometimes capital to massively replicate. So like in India, Muhammad Yunus won the Nobel Peace Prize for kind of open sourcing microcredit, but he was only reaching 200,000 or 300,000 people, which is better than 100,000 people. But they came in, and by the time he left India 8 years later, they'd impacted almost 20 million. Now it's over 100 million people. This is not a small number. Now, in the case of the wheat, it is really rethinking things. And people in COVID have found these brittle, distant supply chains, created a lot of vulnerability. And he is kind of somewhat humorous with like toilet paper, but it wasn't limited to that. If you look at the food system in the area I live in, it was unbroken because the full length of the supply chain in that wheat supply chain is like 25 miles. And so they've moved on without it. And so these type of changes are really resets. And I think it's very clear. When we look back on this time period, 20, 50 years from now, this will be like the Industrial Revolution, right? There's going to be a massive change. All bets are off. There's no loyalty to the status quo by millennials and post-millennials. And just like with media, food, smartphones, ultimately, most of us want what they want. We just don't get it as quickly as they do. So to me, that's the big change going on.
Yeah. Well, today everybody has more information than they've ever had before. They see how other people live and don't live. The broadening gap of what I need, what I want, and what others have is clear and present all the time. So, Dave, I can't thank you enough for joining back with us today on the Business of Healthcare podcast. We're following you closely. I think you're making a good impression, a healthy impression on the people that you meet and the organizations that you work with. So we appreciate that. Thank you once again.
Well, thank you for having me on. Really appreciate it and looking forward to listening to a lot of your episodes.
Thanks for listening to the Business of Healthcare podcast. Join us online at businessofhealthcarepodcast.com to find episode links, notes, and more. Be sure to subscribe to the Business of Healthcare podcast on Apple Podcasts or your favorite podcasting app. To learn more about the Center for Healthcare Leadership and Management, go to jundal.utdallas.edu and then search under the Center and Institutes tab on the navigation menu. Also, we want to hear from you. If you'd like to provide feedback, make suggestions for future guests or show topics, or just want to get in touch with us, email us at healthcarebizpodcast@utdallas.edu. Biz is spelled B-I-Z. And let us know how we're doing. I'm your host, Dr. Bob Kaiser, with the Center for Healthcare Leadership and Management, where we're leading change by changing how we lead.